program initially, and we're very grateful to have her continuous support throughout. So for those of you who don't know Dr. Alya, she's an Omani chartered clinical psychologist. She graduated from the University of Queensland in Australia. And she provides therapy and assessment for both adults and children with a range of mental health concerns. So she's the first trained clinical psychologist in Oman. She's also certified in P parenting. She offers clinical supervision for both employees and graduates in the field of psychology and mental health. She's previously worked in Al Masarra and Ibn Sina Hospital, and she also had administrative roles in the Ministry of Health as well. She practices a range of therapeutic styles, including ACT, CBT, DBT, schema therapy, EMDR, and mindfulness as well. And recently, she's launched her own clinic. So she's a co-founder of Unia Clinic, and she currently provides e-therapy as well. Okay, so Dr. Alya, the mic is all yours now. I think you can start.
Thank you so much, Rawan. Thank you for the introduction. And I must say, it's my pleasure to be part of this initiative. It's so great to see how the profession of psychology is developing in Oman. We do have our challenges, as anyone would, but it's, again, I'm very grateful to be part of it, and I would be happy to assist whenever. So we were asked to pick our own topic. That kind of, gave me a few moments of thinking, okay, what shall I do? What's my audience? And then I thought, how about we just go with one of the main things, the basics, the therapeutic relationship. Many of us just take it for granted, and we assume that, it's something that's going to be established, it's something that we have anyway because we are in this profession. However, we're not going to be really talking about the content as much as we're going to be discussing the process of the therapeutic relationship and some of the challenges that we all face. Just a second. Okay, so the agenda for today, I'd be, as usual, as we normally do, I'd be starting with a little definition, and then we're going to look at why a therapeutic relationship is actually important. Then we're going to look at the different phases, the purpose, and also different types of clients whom we see. I'm going to then take you through the sequence of developing the relationship and what may actually get into the way. And I thought I'll just add a little bit on professionalism. It's quite, I really like to see what people think about this word and, how they define the word professionalism. So that's probably going to take us some discussion. And then after that, we're just going to go through how to move with the client to the treatment goals. And so let me start with the actual definition. In terms of what a therapeutic relationship is, it's ongoing. It's an interactive relationship between the therapist and the client. And the whole idea behind it is to really establish the support for the client to reach their goals. There are many different stages, which we're going to be looking at in a bit, and each stage has different relationship tasks and challenges. And of course, the characteristics include, number one, our own personal awareness and insight, and then many other aspects such as trust, safety, acceptance, to just, and of course, many other things, just to name a few. In terms of why is it important, why is there a need, and why do we actually, spend so much time focusing on this relationship, whether we're studying counseling, whether we're looking more into therapy, or even in any other healthcare professions, whether it's a nurse, a doctor, we always kind of focus on what is the therapeutic relationship. And there seems to be a lot of evidence that says that a good quality therapeutic relationship improves both sides, so patient satisfaction and also professional fulfillment. And it really increases compliance with treatment goals. And in addition, the therapeutic relationship can form a new template. I liked putting the word templates over here for how the clients view other people. So it really is an opportunity for them, an opportunity to get into relationships, an opportunity to experience a secure base. And obviously, I'm referring to ourselves as therapists as the secure base over here. Now, I'd like to share with you a video, and then we're just going to continue.
Existential, psychodynamic, behavioral. There's certainly no shortage of therapies out there. So,
I just want to make sure, can everyone see it? Just a second.
The video isn't working. We can only hear it.
You can only hear it? Okay. Then let me
I think you have to share
it. Yes, I'll just do that. No worries. I will be sharing the video right now. Bear with me. I know that I do this on a daily basis, but I also know that this happens every day as well. There we go.
Existential, psychodynamic, behavioral. There's certainly no shortage of therapies out there. So, which one's the best? Well, the results are in and we have a winner. The most effective type of therapy is all of them. Yes, if you look across all therapies and all clients, they are in fact equally effective. Bit of a shock, but to see what's going on, let's look at what all therapies have in common. From psychoanalysis to CBT, whatever the flavour, what we have are two people in a room, a therapist and a client, working something through. They call it the therapy relationship, and it may just be one of the most important parts of getting better. So, what is it? Well, it's made up of a number of things, such as the feelings the client and the therapist have for each other and how they behave together. For Carl Rogers, the father of person-centered therapy, a good therapy relationship has three key ingredients. Number one, unconditional positive regard. The therapist has to truly think the very best of the client. Number two, empathy. The therapist needs to really get the client. And number three, congruence. The therapist should be genuine. So off with that mask of professionalism. Rogers really believed in his three ingredients. He said they were all a client needed from their therapist in order to get better. Experts say it's so effective because we carry our old relationships around with us. So, say you grew up with a very critical parent. You might now expect criticism from those in charge. In counselling, you can try a different kind of relationship, one defined by positive regard, instead of criticism. It takes some skill to build a good relationship. It's easy to make mistakes, to misunderstand or say something hurtful. Therapists have to know when to speak and when not to, when to show empathy and when to push. They have to be careful not to bring their own bad relationships into the room. Clients should consider their therapy relationship too. If your therapy isn't working, don't just give up altogether. You wouldn't stop getting your hair cut after just one bad hairdresser. Shop around until you find the right therapist and the right relationship for you.
Get more from the Open University. Check out the links on screen now.
Okay, do bear with me. I lost that.
No matter.
And I will be back. All right, we're back. So I'm guessing that gave you quite a clear understanding of it. Really doesn't matter what your theoretical orientation is. It's really back to the actual relationship that we develop with our clients. So let's have a look. Before actually establishing the relationship, let's have a look more about the purpose, different phases, and also different clients that we would be seeing. If we start with the purpose, it really means, who are we seeing and why are we seeing them? So in terms of the profession of psychology, it could take many different modes. So it could be an intake. So you may be working it could be an educational setting, or maybe in a hospital, or even private practice, in a school, whatever it is. It could be an intake. And so that means that you're just going to be seeing the client for the one time. It could be a consultation. It might be it might need more follow-ups. It could be a diagnostic interview, or it could be just in a crisis setting. So maybe in the ER, or maybe something like in primary care. So it's really important for us to figure out what's the purpose of of me being there for the client, and then based on that, you will decide on how you're going to intervene, or how you're going to actually apply your skills, because we might be taking all of the stages in the one setting, or we might be looking at all the different stages of a therapeutic relationship across maybe months as well. Regarding the phases themselves, so there is the preliminary phase, which is the actual first impression. And I mean, just like any other phase, this also is very, very important and quite critical. It could be your first meeting with the client, or it could be the first time they speak to you. Maybe you're the person who spoke to them on the phone, or maybe there was a third person who discussed with them about you. So first impressions are quite important over here. Also the physical setting. I mean, as people, wherever we go, physical setting really, kind of puts a big first impression on us. And so our physical setting is also important over here. And I mean, I'm not talking, make it 100% modern or 100% traditional. I mean, it's really a matter of how well or presentable it is, rather than, whether, the actual stuff that are over there. And it's really, really important to be professional and warm in that first phase. Phase 2, the beginning. The actual development of rapport, building the trust, and keeping in mind that it is very, very hard for people to come in. Not all of them, some of them actually are quite excited and want to be with us, but in general, relatively speaking, clients do feel a bit anxious when they meet someone for the first time. And so again, beginning is also where we actually outline our purpose. Sometimes we may outline our goals as well. So it really depends on, again, on our setting and what exactly are we trying to provide over here. Then come phases 3 and 4. 3 is more of the action. The relationship grows much more. There's a lot of application as well. So lots and lots of application of what we do with our clients in phase 3. And we might find ourselves confronting a bit more, challenging a bit more. And yeah, a lot of things come up in that phase as well. And then comes phase 4, the ending. It is extremely important, and we really don't want to miss the closure. We don't want to miss the last session. Very important to review, consolidate, and to actually demonstrate. So here we're really modeling to our client that we can end a relationship, and we've ended it in a healthy manner. And of course, always to remember to shift the success to the client themselves. In terms of clients, people who we see. Again, I like to kind of divide it into this. Maybe there are many other ways to look at it, but I just thought of sharing how I typically look at my clientele. So there are the few who want to come. They are self-referred, but they find it very, very difficult to engage. And then there are a few who are forced to come. This could be if you're working in a corrective setting, or also sometimes for teenagers where parents say, you have to go, or basically a referral, or sometimes if you're working in an inpatient setting and a person again is in somehow forced to come in. And so we might find it a bit difficult to engage with them. And then there is a whole other set, which are the people who are quite super excited, they're ready to change, and perhaps they're looking more into self-development as well. And this would take us to the actual sequence of developing the relationship. One thing is, how do we actually quiet ourselves? Basically, it's our active listening skills, but it could be a tricky one for us, depending, of course, on the setting and where we are and who's in front of us as well. The other part is the obtaining our valid and reliable information. So whether it's diagnostic or an assessment or just getting our intake, and then of course setting the goals and starting. So, okay. I want to start with our quieting ourselves and developing self-awareness. It's really important because we might find that we kind of we want to straight away go in and jump and want to help out, want to give them our opinion in specific things, and so it's really quite essential actually for us to develop that self-awareness and realize where we are. The main idea over here is to develop the rapport and trust. And so if this is what we're looking at, what exactly are we supposed to follow? Okay. And I'm definitely going to get back to that. I'm just going to move on to something else, and then I'm going to go back to quieting ourselves. And in order to develop rapport, so from a humanistic perspective, we're supposed to be non-judgmental, acceptance of clients, and basically the main three conditions are warmth, empathy, and genuineness. Now, there are many other core skills as well. I have them out over here: having open-ended questions, active listening, validation, objective, encouraging silence, paraphrasing. Now, since this workshop isn't really a workshop on communication skills or counseling skills, I'm not going to go into each one of these. I believe that each one of them is very, obviously very important, and there is a lot to look at into these skills. I've picked two. It was very hard for me to decide what to pick. I ended up picking two, and not because they're more important or anything. I was just like, let me just randomly pick two, again, because I want to focus more on the therapeutic relationship itself instead of skills training. And so the first one I picked was active listening. Some helpful guidelines for all of us regarding active listening. And this is where I mean, we quiet ourselves, and so we really take more of our active listening skills. So sometimes saying the things in a different way, basically reflecting how we perceive the person to be feeling. Another one would be stick with where the person is. And it doesn't mind if the person always comes and talks to you about the same story. Of course, depending on our goals and how we're going to decide to process or proceed, we could slowly move on to something else, but that's fine. I mean, we don't want to always lag behind, and we don't want to always be rather in front of the client, but at the same time, let us be with them. Let us be with them in whatever mindset they are, in order for them to feel understood and validated, and then we could move on to whatever stage that we have in mind. Speak with the same feeling the client has. This is quite important, because we might be having a good day, we might be excited, we might, maybe we just heard some good personal news, and then we have a client who's not having the best time. Maybe a client who is feeling a bit angry or sad, or whatever it is. Feelings are feelings. So it's really quite important for us to kind of be self-aware and realize, am I too edgy? Am I too excited? Or am I myself feeling so low and gloomy? And so it's really important for us to kind of validate and have the same feeling as the client has in session. And if they're low, we go low. If they're more happy, even changing our tone of voice, kind of mirroring in a way, but not to overdo it, because if we overdo it, it gets very, very annoying, obviously. And using reflective listening only when you can feel accepting of the other person. Some more of active listening. So use reflective listening when the other person talks or expresses about feelings and sharing ideas. Also, when they're angry or resistant, we could actually pause and tell them, it seems like the situation made you feel very angry. So we heard. Maybe the person wasn't able to label their emotions, but we actually got it out and we're reflecting back. That means that we were there for them. We did good listening skills. And also when you're not sure about something, whether you understand it and when you check it, or if you're unsure and you want to know what the other person means. So you could just go with a statement, something like, so you told me that your teenager wasn't joining you for the meals for the past week, and that was okay with you. So what I did right now is I basically took the facts and I reflected the actual statement. This person says that their teenager hasn't been having meals for them, and then I added that it didn't really cause them any issues, and it was it was fine with you. It didn't cause you any issues. And also note that I shouldn't be judgmental, as in, oh, and you thought that was okay, or and oh, you thought that nothing, that was absolutely fine with you. Just try to make it as neutral as possible, just reflecting and summarizing. And basically the whole idea is when we listen, we're telling the other person that they're important and I want to understand them. One thing we do hear about is encouraging silence. So this is the second thing that I picked. I picked the active listening, and then I picked the encouraging silence. It may get a bit awkward at times, but I would recommend it if we really don't know what to say. If you don't know what to say, it's better to be quiet instead of just going with the most impulsive thing that you have, because it might be judgmental, or it might be something that comes from you as a person instead of you as a therapist. So sometimes such statements as "let's pause for a moment," or "it's okay with me if you want to think about it for a while," or just like "when you're ready we can talk about it." Again, depending on the situation and depending on where you are in session, or even if it's the first time that you see them. So I would definitely encourage silence. Okay, now I guess this is a good time to ask a few of you. I'm not sure how the panel is going to take this. So my question is, what may get into the way? So I gave you a few things, and we're talking about therapeutic relationship. I'm wondering, according to the audience, what do you think may get in the way from your practice or even from theory? What is it that may block us from time to time? So is there anyone that would like to participate?
We have someone that's answering an unresponsive client, maybe with stoic expressions.
Sorry, again, with what?
Stoic expressions.
Okay, so that's if the so do you mean more like non-verbals?
Maybe Sangeeta clarify what she meant by that. Yeah, basically expressionless.
Yeah, sure. Okay, absolutely. Anything else? Do you think that other things might come into the way? Things from us as therapists. We know what to do. We definitely know what to do. But sometimes in practice, we might, be like, oh, I don't believe I did this, or oh, it's like, oh, I don't want to go. I don't want to attend this session, or this is something new. What do you think? Are there any stuff that may get in the way?
Sometimes you might get preoccupied by a different client, for example. Let's say if you have a busy schedule.
Absolutely, you're trying to problem solve over there. Yeah. Okay, thanks for participating. Let me get back. I do have many slides for this, so let's see. Okay. One thing that may get in the way of developing the therapeutic relationship that we want to develop is our own biases, our own stereotypes. Sometimes we don't even realize it until we are in a specific situation. We might not realize that we hold specific beliefs, or when we be like, no, I'm not that type of a person. But then suddenly, in a specific context, you'll be like, oh, really? This is what somebody else told me, or this is how I reacted. So notice your own stereotypes, your own your own likes and dislikes, and we as humans we all have that. It's of course, when it's an extreme, it's an issue, but being therapists, we should be aware about our own stereotypes. Something that I find very common in the medical field, again, no offense to any of our medical professionals over here or our colleagues, but sometimes I do find this is when if there's an elderly, especially also something related to our community. So if there is an elderly, and the elderly comes with the son or daughter, and so the professional would straight away move towards the son or the daughter and would ask them, how is he spending his day? Or does he take his medication? So straight away, we're not building that relationship with the actual client. Now, who is here for us? It is the elderly. And so it would be much more useful if we actually build it with them, instead of an assumption that this person is old. So again, we could, again, find out who you are. We may be a bit racist, we may be a bit sexist, we may be sometimes, ageist. I don't know. I'm not saying everyone is. I'm just saying whatever you have, the more you dig in, the better it is. Because at a specific situation, you may be surprised that this thing actually came out of you, and also regarding specific groups as well. And so how would you react in a different situation with different people? And so I would suggest, do go to different situations, as much as we can, whether it's training or whether it's an attachment somewhere. The more we expose ourselves, the better it is, because we're going to gain so many skills, and we're going to realize how am I able to actually build this relationship. Okay. many more. All right. So other things that may get into the way of actually building this therapeutic relationship is the fix-it mode. Now, as therapists, why are we in this profession to begin with? Because we're like, we want to help people. It's something we have, we're genuine, we're kind. I'm assuming most of us are. So this is what we want to do. But then we might get into the trap of, I want to fix it. I have to help you. And there's a lot of research and evidence that shows that therapists may fall under the trap of, or under the schemas of self-sacrifice or unrelenting standards. Which basically means self-sacrifice means that I will do anything for my client. So I will not look after myself. I will work very long hours. I will, I'm gonna take more clients that I can, or I'm gonna do this, and on and on and on. It's because I feel that I need to do it. And another thing is when we have unrelenting standards. Again, many therapists actually do end up finding out that they do have this specific schema, and so it's more of the perfectionist. I want to be perfect in this. I want to do it right. And again, there's nothing wrong with these per se. It's if they take over. And if we find ourselves, like, for example, an unrelenting standard would be, I can work with any client, any presentation, you give it to me and I will handle it. Now, I don't think that we can do that. We tend to have specific specialities or specific areas where we might be better at, which by default means that we're not good in other areas. So it's better to actually refer to someone who's a specialist instead of me saying that I can do it all, because then I would be affecting my client. And that's what obviously counts more. And so let the client self-explore and assist them in managing instead of us being the fix-it person. Other stuff that may also get in the way, the I know it mode. Now, this is also very, very common. I'm talking about our culture because we really follow a medical model. A biopsychosocial model isn't really implemented in our healthcare systems yet. And so we may get into the trap of, I'm the expert and you listen, I'm here, I tell you what to do. In a therapeutic relationship, we've already defined that it's two-way. So that means even if I know, I have to listen and I have to make them know what I know. We can't just let them know what it is. It's a two-way relationship and it takes time. And they have the right to know that. The client should be aware that, I do have my expertise, but then you are the expert in your life, you are the expert in your self, and so it's a two-way relationship. And this is where we should really watch out, the idea of giving advice. Never give your advice, because obviously it comes from your personal experience, and that is, the number one taboo in a therapeutic relationship. Another very, very common one is, I know exactly how you feel. Now, it is a very natural response because, we're really conveying empathy over here. It's like, I know exactly what you feel and I'm sorry that you're going through this. But then sometimes it might not be the best thing to choose because it can invalidate that this is such a unique experience. And maybe you really don't know how they feel. You're definitely not in that situation. So instead, it would be quite useful to say that we would reflect that this is a very hard place for you, and I understand how distressing the situation is, or I understand how hard it is for you at this moment. So I am validating. I am showing them that I can see how hard it is, but I'm not telling them verbatim, I know exactly how you feel. Let's see, other things that may also get into the way. Actually, before that, I'm just wondering if anyone has any questions on this. You don't have to. I'm just, I'm just leaving it open. If there's anyone who has any questions, anything about these specific traps. Nothing, Rawan? We're not getting any questions?
No questions. I can see.
All right, no worries. Okay, then let me move on. That will take me to other things that again get into the way of the therapeutic relationship. Transference and countertransference. Again, these are basics. I'm sure, if you are a professional, you have definitely heard and been, educated about these specific terms. And so transference is when the client kind of sees you as someone they know. They may be reacting too much to you. They may be liking you more than anyone else, so because you remind them of someone. Or they may hate you because you might be reminding them of that specific teacher or parent who wasn't fair to them. And so therapy ends up being about us instead of the actual client. And this is quite hard. And so it's also important to know how to bring it up and how to discuss it with the client. I remember in one of so way back when I actually had maybe my first or second training in mental health, I had a client who used to come in the clinic. So this was in an academic-based setting. So I was doing an internship, and every time she would come in, she would see me. She would want to come and hug me, but I would always, kind of push her. It was just, very, very inappropriate. She would take off her shoes and then just, cross her legs, sit down, and literally bring her, just stare at me, admire. It was so awkward. And I was, back then, I was still a student, and I had no idea, what am I supposed to do over here? Until I took it to my supervisor, and my supervisor was like, and what does she tell you? Who does she think you are? So we're not talking delusions. We're just talking about how this person is identifying to us. There are limits, there are boundaries. So when we feel that something isn't good, number one, take it to a supervisor, take it to a colleague, discuss it, and then brainstorm and find out how are you going to discuss it with your client. The other is countertransference. So it's when we, as professionals, as therapists, when we have intense feelings, attraction, repulsion, whatever it is, this client may be reminding you of someone. Maybe you've been through something personally. Maybe you're, maybe you're grieving. Maybe we have experienced a loss in our life, and so somebody comes who has similar difficulties. And again, there's something not right. Maybe as they're talking, you're remembering your story in something very, very similar. And so this is a good time to actually pause and ask ourselves and, kind of self-reflect. Is it right for me to continue to see this person, or shall I refer? If we can refer, that would definitely be the best way to manage it. And again, discussing with a colleague and a supervisor, whatever it is. Now, sometimes I get asked, what if there's no one else? We do have very remote and very limited services. It is a fact. What if there's nobody else? So I think it really depends on our clinical judgment. Are we doing harm or no? And can we, for example, consult with someone just to make sure that we are on the right track, or no, with the client? Because again, by the end of it, it's all about our relationship with the client. Are we getting to the goals? Are we doing what we need to do or not? Let's move on. Okay. Anything else? I'd like to hear, please, if anyone has and again, if you want to share any examples, or if you feel there's anything else that might get into the way of our therapeutic relationship at any stage. So go ahead if there's anyone, whether you want to write it and Rawan reads the questions, or even if you guys, again, if you want to just speak up, I leave it completely up to you.
If anyone wants to unmute their mic, you can raise your hand and we can unmute you as well. So Sangeeta is saying an experience from our own past that is similar to the client's issue now.
Mm-hmm. Okay. Yeah. So when something like this comes up, definitely it's counter transference, and so we should be quite aware about it. And yeah, and then take basically take a step backwards, especially if it's going to affect. If it's probably going to affect us as well. Anyone else has a comment?
As well, if it's not allowed to give therapy to a known person, but what if the client really insists to meet you? So I think they mean that if it's someone you know personally, and how would you respond to actually meet the therapist for them?
Yeah, that's a very good question, actually. And again, giving the remote. I do say we do have remote services here in speaking specifically about Oman. We have very limited services, and sometimes you would end up being in this awkward situation. So I would say, again, it really depends on their level. If you know them too well, it just wouldn't work. It wouldn't work because emotions rule, and just other things come into the way, and you won't be able to give them what you want to give them. It might be, even if it's let me tell you an example I had. So I had a person whom I knew very well, and then I felt it awkward because they're like, "So Alya, do we pay you?" And I was like, okay, this from the beginning, it's awkward. So do they want a friendship? Do they want what exactly do they want? Because if it's professional, then yes, they have to pay me because currently I'm in private practice. It would be very, very awkward. Or also they'd be like, can we change the appointment all the time? Or maybe they'd be WhatsApping you, So it's different. And so you will not be the therapist. You will not be the therapist who you want to be. Self-awareness and really using your clinical judgment. In general, if you know the person, no, but because we are in a very limited basically in an area with a very limited amount of professionals, it depends. I would say it depends how well. So if it's the random cousin who you would see but you never talk to, go ahead, because you really don't know them well. Or someone who used to go to school with before but wasn't in your class and you really don't know them, again, that's okay. Anyone else?
It's the second one because someone else was asking if it's family, so that answered that as well. There's someone asking, I was wondering, what if the client is not willing to change? Like, let's assume lack of motivation and belief. How would you handle such a situation?
Okay, so it really depends also on the presentation of this client, and number one, whether they are self-referred or they are basically they're told to come and see us. If they're told to come and see us, then throw it on the on policies and procedures. Don't make it a personal issue. I know you're here, and I know that you don't want to see me, but we just got to do what we got to do. So kind of really throw it on something else instead of the actual relationship. Now, typically, when people are not motivated to work on things, they may be expressing, or they may be going through symptoms of depression, if not actually diagnosed with depression. So I would say we really follow maybe motivational interviewing skills. We go very behavioral in the beginning. If your focus is to alleviate symptoms, it might not really work at that time, because we don't have the magic wand to just magically take away depression or just magically take away anxiety. Goals have to be more behavioral. So what would you be doing if depression wasn't there? Or, how will you be engaging with your family if you felt better? Behavioral, focus behavioral. It might kind of, make them more, I guess, motivated again. But again, in terms of specific skills, I might need to park this on the side, because then, it's going to be more of a skills training of, again, specifically motivational interviewing. I hope that answers the question. I can take one more question if there is, and then I'll move on.
The last question was, I think, what do you do when the client is too biased to his religion or based on his religion?
Okay, I would just go with the client, and then I'm just wondering, how does that affect in achieving goals? If it's something, and I'm checking out, am I not happy with it? If the person is too religious, does that mean that I'm not happy with it? So again, kind of some personal, self-reflection. Why am I not liking this? Do I feel that the person is judging me, for example? So if it's something that you feel that's coming up in the session, bring it up. There's something that's called meta-communication. I'm going to be discussing it a bit later on today. So it's really about talking. If the person is also very, very rigid, we try to show them. So, if even some rigidity comes up in session, if they're, too stuck on something, and then we tell them, oh, you see what happened here? I'm wondering, is this what happens when you're out there with your wife? Or is this what happens when you're out there at work? So then we enlighten them that because they're so rigid, they're unable to actually have good relationships. Again, I'm kind of assuming because I don't have enough information, but I hope that kind of answers your question. Okay. So I guess we're good to move on then. All right. Again, I put on our own culture beliefs. What are our own judgments? Being non-directive, are there any pitfalls of being non-directive, or is it okay to be non-directive? Different theoretical orientations have a different stance over here, but I definitely go with clinical judgment on where you are and who's in front of you at that moment. Okay. All right. This is another place where I would like to also engage the audience some more. The word professionalism, what does professional mean? How professional are you? I'd really like to hear from people about, what do you hear about the word professionalism? Anything about being professional?
Sangeeta's saying where we know our boundaries, where we know where both our boundaries lie.
Mm-hmm. Okay, so setting boundaries and being aware of what our boundaries are, definitely. I mean, example could be like, I'm your therapist here, so you don't have my personal number and you don't call me, as an example, or I don't go out for coffee with you.
Mm-hmm. We also have keeping clear boundaries as well, having good practice skills.
Mm-hmm. Okay, with practice skills, absolutely. Yes, we need to know, again, how do we apply those skills that we're taught or that we're reading? Absolutely.
We also have knowing how to balance between our private and work lives.
Mm-hmm. Mm-hmm. That's a very good one. So self-disclosure, actually, I'm surprised I don't have that on my slides. Thank you for the person who said that. Self-disclosure is a very, very big one, because this is not a friendship. This is, again, a therapeutic relationship. So, we take, but we don't give a lot. We don't tell them about our own personal struggles. But then again, this person also mentioned the balance. So it's okay to say, oh, I had a bad day, or, I'm sorry, I was, caught up in traffic, or even think like, my kids are not in school today, assuming we're back to the norm. So the balance between what to share, how to share, And sometimes in therapy, there are moments where we would choose to self-disclose. And, these might be like, a big aha moment, but again, it depends on your theoretical orientation, and I don't want to go to therapy. So yes, definitely a very good points. Anything else regarding professionalism?
Ethics, being aware of the ethics, confidentiality, privacy, etc. Being punctual, being flexible, informed consent.
Absolutely. Yes, these are all essentials, the ethics, the guidelines, informed consent. Consent is not just consent, it's informed consent, and that informed means a lot. So they really need to know what is it that they're getting into, and whether we sign it or not. Again, depending where you work, there are places where actually signing a document is needed. If maybe public health doesn't follow that as much, but private practice follows that as well. So yeah, definitely. Okay. I always tend to look at also the way that we dress up. I think it's something that comes into, I don't know, I always have that in mind. And, being professional, how you dress up. And it doesn't really mean whether you're covered up or not, if you're a female over here. But, like even, like as we say, زي rasmi. So, the guys put their masar in Oman, it just makes us look a bit more, as we say, professional. And also, even in the Western world, so it wouldn't be accepted if you're wearing jeans, for example. Just the actual material of jeans doesn't mean that it's professional. Sometimes sneakers, although sneakers now are kind of more in fashion, but it's those things that do count, and we should be aware about what does being professional mean. Thanks for those of you who shared. Is there anything else, Rawan, that was shared?
The last one was using evidence-based therapy.
Absolutely. This is what we should be doing. Evidence-based is basically the right way to do. We want to make sure that we're providing in the right manner. It might take us longer to get a degree. It might be a bit harder, but it is the right way to do, because again, we know it's based on evidence. It's not some random thing that a random theory that somebody came up with. We know that it's applicable. If it's evidence-based, that means it's applicable. That means that there have been randomized trials proving that this thing does work. This also takes us to very cultural beliefs that this is a hocus pocus thing. What is therapy? It's just a little bit of magic. But no, it's not that. It's not magic. It's real evidence. And sometimes people are just not aware that this actually is science, and we have to really study it. It's not just whatever comes into my mind that I tell you. Very, very culturally linked. And so I guess it's our duty to raise this awareness and let people know, are they using an evidence-based strategy or not? All right, thank you for that. I'll be moving on. And yeah, so basically what I had is really the balance between empathy and objectivity. So this is another thing. If you just look in a dictionary what professionalism is, you might realize that being professional means no emotions, or being very very objective, putting everything on the side. But it can get a bit tricky in our profession, because we've just been going on about empathy and how important empathy is. So we don't want to be sympathy. We don't want to go to that end where, again, so our schemas may take over or our emotions may take over. But at the same time, we don't want to be 100% objective and just be so rigid. So being professional also comes in this. So if the person, really was sick and couldn't make it to the appointment, then, we have to be humans over here. Yeah, the person was sick. It has nothing to do with me. It's not that the person doesn't like me. The person was sick. And of course, many, many other things come in. So being professional doesn't mean that we shut off emotions. It doesn't mean that we just look at, the way that we look, or the place that I'm working at doesn't have to be like, the most prestigious place. No, not at all. Being professional, you could be professional in a very, nasty place that has nothing to do with the actual environment. I think it has a lot to do with who you are, how you observe yourself, and how you observe this profession as well. All right, we'll be moving on. Okay, I have another video, so bear with me. I will be stopping sharing and then resharing. Let me get this right. Sharing.
What do you do to develop?
Just a second.
What do you do to develop a good therapeutic alliance with your clients?
One thing is just to start with those basic therapeutic counseling skills. So the empathy, the being warm and genuine, the showing interest, like, leaning in, using your body language, using your facial expressions. And that can really help develop that trust between you and your client.
Something else I keep in mind is I look for and listen for any opportunity to give positive reinforcement, particularly with patients who are depressed. They are not feeling particularly good about themselves. There's often a lot of critical thinking going on. And if there's anything they talk about that they could give themselves credit for, I point that out.
Also, what helps is when we do something that works in that moment. There's a patient that I saw yesterday. I asked him what he wanted to put on the agenda. He said, I just want something to make me feel calm right now. I just want to feel calm right now. So I led him through on that agenda item, what he wanted to work on, what he was motivated for, of doing a relaxation exercise, of doing visualization exercise, of doing, enabling to watch some of his thoughts at that point. And at the end of the session, he was a satisfied customer. Nothing succeeds like success.
So the relationship really gets strengthened when clients see that you're helping them.
Yeah, when you give them something that works.
Okay. And we are back. All right, again, we got to see three different perspectives about the therapeutic alliance. And yeah, it was very clear. Finding the right time, using the right skills, and also listening to what they want from us instead of us imposing what we think is the right thing to do. Okay. This takes us to the third stage, which is reliable assessment and information. I think this really depends on your theoretical orientation, where you're coming from, what background do you have, and also the setting. Is this a diagnostic interview? Is this an intake? Is this an intake over the phone where you're just getting, or maybe, a screening intake? It really depends on where you are. And to me, this is the best part to observe. I love observing in this stage. You could observe as much as you want, and the calmer you are, the better your client will feel in terms of developing the relationship. Basically, you're letting them know, I'm here, take your time, but also there is some structure. So, keeping in mind that, you could tell them that, bear with me, I've got a few questions I need to ask you. And, some of the questions may be repetitive, but I just need to do this because it's part of what it is. So tell them exactly what it is. And don't be sorry for it. Like, I'm sorry. There's nothing to be sorry about. This is the procedure. Again, people in our culture, specifically, I'm talking about Oman. People are not aware of what a therapeutic relationship is per se, because we are so used to a medical model, and we're so used to the professional versus myself, the patient, who really doesn't know much, and so they just literally just look up to us for us to feed them. So this is not a therapeutic relationship. We want to define something different. So observe, take your time, observe, and obviously do what you need to do in terms of reliable assessment and information. Other issues that may come up from the first impression would be things like, what if the client might tell you, so as you're talking, the client might say, don't you agree? Don't you agree with me? And you're like, hell no, I don't agree. But also notice, are you going to reply the way that I just replied right now, or not? What are you going to say? So sometimes we don't really have to answer them, or you might be like, well, I'm not sure I actually get you. Or maybe you could say something like, what would it mean to you if I don't agree? Because that might just blow something up, and it's quite important for us to find out why do they want us to agree. But then also notice, because sometimes we may get pressurized, even specifically if you're working with parents. So a parent might talk to you about their kids, and parents might actually want us to fix kids, not knowing that we need to work with the parents instead of actually working with the kids. And so they'd be like, this is what I think that's happening or ongoing with my kid, and don't you agree with me? Or even sometimes in marriage counseling, you might have the actual the couple right in front of you, and someone would say something and then would look at you and be like, don't you agree? And you do, and you don't want to be biased over here, you don't want to be here, and you don't want to be here. So notice your immediate reaction, notice your nonverbals as well. You don't want to be leaning towards or leaning away. Notice, kind of, put yourself back into perspective, look at them as straight as you can, and really try to look at the process over here instead of the actual content of what they're trying to tell you. What if you feel you're talked at? Again, maybe the person is basically shutting you up, not letting you talk. These are common things. They happen every day, everywhere. So we should really be aware of these specific situations. What if you're bored? What if you're bored? Honestly, what if the client goes on and on and on about something, and you, as a therapist, instead of attending, you're thinking, this is so boring, I don't want to listen to this person's life story. And these are indicators for us. Do we go through them? Yes, we can go through them, but they're also indicators for us to self-reflect and to realize, if this happens, what do I do? Who do I consult? Is this also, if you're working in a team, sometimes, again, depending on our setting, there may be other people whom we're working with. Do they also feel the same thing? How judgmental are we? Or sometimes as a team, maybe if we're working in a hospital, we might be like, oh, guess what? The difficult client is booked in today. So this by itself is quite judgmental, and it also shows that we've labeled this person difficult. Yes, this person may be complex. This person may definitely be very complex, but why are they coming? Why are they coming? What are they looking for? How objective can you be to assist them? And by all means, we don't have to like all our clients. We're human. We may not like our clients, but that doesn't mean that we don't follow our protocols, our agreements, and try as much as we can to be there for them, to help them. And again, if you feel that you really can't, refer out. There is nothing wrong with referring your client. What is it? Actually, one thing about Are You Bored? Maybe I would share with you guys something that I felt. I didn't. Once I had a client, and it was very funny how I actually ended up diagnosing them with a colleague of mine. It turns out that she was what do you call it? Now I forgot the name of the diagnosis. Not histrionic. So it was a histrionic personality disorder, and this was maybe one of my first times, because again, people with personality disorders don't randomly knock at your door and come to seek therapy. And so this was a person with histrionic personality disorder, and as I was trying to brainstorm, it was with a colleague of mine, and we're thinking, what is it? And then my colleague asked me, they're like, Alya, were you bored? And I'm like, yeah, this is what I felt. I felt that I was actually bored because of how much she was talking about herself and da 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 da. And then we're kind of looking into different criteria and stuff. Now, I'm not saying this is how you diagnose a person. Please, don't take it to that extreme. But I'm saying my own personal reflection and how it affected to me, and how that straight away triggered. And then, I took it into, we looked at everything else, and then we realized, okay, this person fits in this diagnostic criteria. And then, it worked well. And so every time she came in, the moment I noticed it, I'm like, this is it. And then, I'd be focusing and then walking basically with her and her own therapeutic goals. So, there you go. You'd be surprised, but you should always notice and see what is it that happens to you. And okay, this brings me to meta-communication. I know I touched on this a little bit at the beginning. And so it's basically talking about talking, and this is process. This is what happens. So if the client always comes to you and the client is always snapping at you, the client is always angry with you, talk about it, and also throw it on the process. So I'm wondering, I feel that whenever we're here and we're talking about work, you become very snappy. It's something that it seems that it's not something that you're comfortable to talk about, and you try to avoid and take me to a completely different track. So I'm wondering what's happening in this process over here. And so this really, the whole idea is to help the client notice the process of engaging with the thought. Is it a judgment? Is it a story? And are we actually arguing regarding the process than the content itself? And then ask the client, is this typically how you react when you are feeling angry? Is this typically what you do in your real life when you are feeling angry? So meta-communication is a big one in a therapeutic relationship, definitely. Okay, this may take me to an end. No, okay, not yet. All right. Yes, so then after that, so we built the actual relationship. Then comes the task agreement, the actual goals. Why are they here, and what is it that we're going to be working on? And so identifying goals. So I mentioned this before. Try to focus on behavioral goals. Behavioral goals are much easier and more easier to achieve, that is, and also more tangible. If a person is just looking for symptom reduction, which is very, very common, they'll be like, I don't want to feel anxious, I don't want to feel depressed, but the focus is symptom reduction. I'm wondering how are we going to measure it? And to be honest, symptom reduction is perfect with medication. So, if that is the only goal, so go to see a psychiatrist, and you would definitely get reduction in symptoms. Maybe again, depending on where the client is, it might be the right thing to do. Maybe they really need to have a reduction in symptoms and then work on therapy or do it together. Or they just don't know what is it that they want. So focus on behavior goals. If you were feeling less depressed, what will you be doing? Will you be with your family more? What will you be doing with your family? If it's something to do with maybe if you were less anxious, what will you be doing in terms of studying? Develop a plan for studying and focusing and attention training. So the more that we have something tangible, the more likely that we're going to be able to achieve it and actually, put a check mark that yes, we've done it. Identify goals and how therapy will address these goals. So obviously focus on the goals, identify them, and then tell them, maybe we're going to be doing some exposure to look at this. Maybe we're going to be doing some behavior activation to help to look at this. And I'm just using the CBT model over here because I'm assuming it's a very common orientation that people follow. 3 would be give respect to their capabilities and their judgments. So have a look at what their skills are. How much skills do they have? Do they need more skills training? See where they are so you know how to assist them. Provide expertise about what you think may be helpful in providing them to achieve their goals. So after doing all of this, then you could give in your own advice based on the theoretical orientation that you're using. So there's no harm. Obviously, we do know that we are the experts over here. Yes, I did mention that they are the experts in their lives, but also they're here for our assistance. So we could help them out and lay down the options, and then definitely remind them that everything is negotiable. This is what makes it a two-way relationship. So tell me if it's not working. And then we have to model acceptance. So if they tell you, look, I just cannot do this, we have to accept it. Model feedback, model vulnerability. So tell them, that I really don't know. Most likely, because it's an evidence-based intervention, most likely this will assist you. But I'm not, 100% sure. I'm going to be with you to get you to your goal, but there's nothing that's 100% guaranteed, of course. And so, how much do I promise? And I think this is my last slide, if I'm not mistaken. We'll find out this together. So, how much do I promise? Is there a 100% guarantee? We lay down the evidence. We discussed that, given these circumstances, given where we are right now, we look at, the overall, the psychosocial, we look at everything around us. We do even a formulation if it's applicable. One of the best things to move forward is to tell them, hey, this is an experiment. Let's find out. This is new to the two of us. So this particular relationship is a new relationship, and this particular route is a new route. So it is an experiment. You may do well, you may not. And if not, we'll find out why and we'll fix it. And if you will, then we're definitely going to make sure to find out how we're going to maintain it. And of course, there's a trial and error. Again, define a two-way relationship. Tell me if it's not working. And I just touched on that. Model acceptance, feedback, and vulnerability. What is expected between sessions? They do the work, not us. We don't do the work. They do most of the work. So expectations. Again, this is something that many of us may feel as something that may get into the way. Within our culture, because people aren't used to doing much. So we have to teach them, and we have to follow them, and we have to guide them and coach them that they actually need to do some work between sessions. And one of the very, very important things is it will be hard, but I will be there. So the secure relationship. We are building a secure relationship. Just like parents and kids, You know, we tell them to go. First day of school will be difficult, but you're going to come back home. So, you know, go and try it out, but then you do know that home is still home. And definitely, you know, one of our main goals is also to build resiliency and independence for our clients, because we don't want them to come back and tell us, oh, you did everything for me. They should know that it's, you know, we facilitated, but they did most of the work. And so, yes, this was my last slide. This takes me to an end. I know that I probably finished a bit before time, but yeah, feel free if you guys want to ask any questions, please do go ahead. If you want me to elaborate on anything, I leave it completely up to you.
If anyone also wants to talk, you can raise your hand and we'll unmute your mic as well.
Anything?
Okay, so someone has a question on compliance of homework after sessions and any tips on that?
Okay. Well, we definitely let them know in session to begin with why we want them to do the homework. I tend to use the word task instead of homework. People don't like to hear the word homework. Sometimes we joke about it. So the moment they realize it's a task, they like it. I don't know. That could be one thing. But if they don't do it, it's okay. Once they come back, don't tell them off. Use the session time to actually do the homework. It may be they just didn't understand. So going back to before giving them the homework, ask them to repeat, to actually tell you what is it that they're going to do. Because they might just nod and say, yes, okay, we got it. Yes, I'm going to do this, but then they don't really understand. So just tell them, okay, how about you tell me, what is it that you're going to do from now to next session? And also, do you want us to demonstrate? Do you want us to do an example? So that makes sure, that kind of takes care of the understanding bit. If they don't do it for other reasons, then we need to find out why is there a resistance. Is the homework too much for them? Is it evoking other emotions that we need to address? So I guess, again, depending on where you are, we need to dig in. Never tell them off for not doing it. If it's just out of complete laziness, do it in session. Let them see that this is important and it needs to be done.
Okay, we have another question. What is the biggest challenge you have faced as a therapist?
Okay, well, that's a big one. I can't really get one. Okay, perhaps the lack of having many colleagues in the field, I would say, is a challenge, and being surrounded by a very medical model, so it's a bit difficult for people to also engage. So the stigma that surrounds us here in the community. Having said that, I mean, I've been working for, haven't reached 20 years, I think maybe 18 or 19 years. So it is a huge difference to how it was before and how it is right now. More people are coming in. And perhaps when I was in also working back in the government, I used to work in Ibn Sina and in Masarra Hospital. So yeah, these were, hardcore mental health centers. And again, I guess when I find out that one of the clients committed suicide, that's very hard. That's really hard. So how to deal with it, yeah. Anything else?
We have another question that what are the best books that can develop our skills for therapy sessions, especially when dealing with adolescents and children?
That would really come back to your theoretical orientation. My library is right across over there, so I can't just go and pick. I do have many books. I mean, if you want, you could email me or DM on our Insta. I would look back. I can't really think of specific books right now. I am more of an ACT therapist, acceptance and commitment therapy. So most of my books are in that direction. I could guide you, and also some parenting books as well. I could definitely guide you and perhaps give you some names of some well-known therapists in this field.
So after the session, we'll be sending out an email
Okay.
with of today's workshop, so we can add the list of books to that as well.
Yes, sure. I would do
that. Another question is, if during therapy the client had improvement but again relapsed while trying his or her best, what's the solution here?
Okay, number one, don't be disappointed. This is part of it. So for us and for them, they should know relapse is part of the cycle. If it happens, we should really address it at that time. So at the moment, what is it? What went wrong? Sometimes there are changes outside of our control, that something probably happened. If not, then it's something inside. So whether it's cognitions, whether if it's, you're going through a hard time. And so definitely dig in more and find out more, but do know that this is absolutely part of the process. We're never gonna, we can't just ace it from the first time. So again, going back, consolidating, doing the same things again, and letting them know that this is life. One of the main important things is to notice that if you dip in, you don't go as deep as you normally would, and you don't go as long as you would. So if this is the dip, we would then want it to be like this and like this and like this until there's no longer. So there always will be dips, but we want their duration and their intensity to be less until we could actually manage it.
So I think that's clear for that one. We have another question that they're asking, what is one advice you have for aspiring therapists that balance studying therapy further in graduate school?
Sorry, again, that's what?
Studying therapy further at a graduate school level.
So, okay, seek supervision. That's what I would say. Take your risks if you can. Go to trainings, even at the beginning. Don't even think that there would be attachments or internships would be paid. It will pay off later. So take non-paid internships. Even in places that you would never think that you'd actually like, and seek supervision. It's gonna make a huge difference. I never thought that I would be working with kids, but I forced myself to take an attachment in a lovely parenting setting, and it helped me personally with my own kids, and now I feel quite competent to work with parents as well. So you never know. Don't put a limit.
So explore new areas
as much as we can.
Someone's asking, a therapist's career is stressful in general. So how do you manage stress, feeling low, or even burnout in terms of career, spirit, and your mental health as a therapist?
Mm-hmm. Absolutely, a very good point that you shared. So self-care is number one. Again, going back to unrelenting standards and self-sacrifice, maybe many of us have that, but putting a limit, putting a boundary for myself, and realizing I can't do it all. And so looking after yourself. And again, I go back to the same word, supervision, whether it's you having a supervisor or peer supervision, because as you mentioned, this is a difficult discipline. And we can't just randomly talk to people about it. You can't just pick up the phone and talk to your mom about it or to your best friend about it. There are times where you do need to talk to a colleague about and just process some things, because it can be stressful. And also what I do. So I'm now in private practice. I used to be in public health. If I find that I have many diagnosed clients with personality disorders, I spread them. I can't do. This is me personally. I can't do many personality disorders in the one day. It really takes away from me. So I know how to spread myself. There are times where I say no and I don't like it, but this is it. So if you need to say no to a specific caseload, say it. You have to look after yourself. And definitely the balance. We ask our clients to balance, so we should also balance our health, our personal lives, our own hobbies, our whatever it is. And if you find yourself going down the spiral, again, supervision. Anything else?
Whatever works best for each individual, like differ.
Yes, absolutely.
Someone wanted to know how to deal with parents who want to stop bringing their child to therapy because they have the fix-it ideology.
Because parents have the fix-it. Okay. Yeah. So unfortunately, see that we may go through such experiences where how much can you do? So it really depends. It depends. Now, if there is abuse or neglect, then maybe there's a different route to this. But then again, not bringing them by itself may be harm. So even for us, so we're not going to go there and scold the parents, because they're going to tell you, who are you? I am the parent. I know what I'm going to do. So trying with any other professionals, any other ways, or even sometimes just telling them, okay, I respect what you're saying. Can you just share with me what is it that you're gonna, how is it that you're gonna manage it? And perhaps if you could come in after 2 months, after 3 months, give them some time, let them realize that it didn't work. Now, some people are more stubborn. And again, it doesn't mean that it's us who didn't do it. You will sometimes be in situations where it's very, very hard, where that you could have helped, but unfortunately they chose not to. So don't blame yourself. I would definitely say don't take the blame, but do try. And sometimes it works. Even with individuals, we're like, there's no way I'm going to do this. I'm like, fine, I totally respect. Just let me know, what is it that you're going to do? Yes. Okay, will it be all right if you come and see me after 2 months, after 3 months? And sometimes they do come back and they do say, guess what, it didn't work. So I don't know if this is something that's possible or not. Just thinking outside the box.
So I think that clarifies that question. So overall, I think we've covered all the questions. Someone was asking if we can share the presentation afterwards, so if that would be okay with you.
I believe it's actually recorded, right, on YouTube. It's going to be there. Is that correct?
Yeah. We're going to record. We're recording the whole workshop, and we're going to upload it on YouTube.
All right. So I think I'll also share it out.
Okay. So we can send you guys the link after we're done. So we just want to take the opportunity and thank Dr. Alya for this very enriching workshop today.
Thank you again for having me.
We're very grateful to have you with us. And we want to remind everyone that we'll be hosting 2 other workshops next week. So the first workshop is going to be on Monday, and it's going to be on psychological first aid. And the workshops next week are going to be in Arabic. So if you want more details for the workshops, you can access them on the website. And we'll be sharing details on social media as well. So if you can look out for them. Okay. So we have good feedback, Dr. Alya. Everyone's thanking you for your time and very informative session.
Thank you, my pleasure.
And if you'd like to add anything?
I guess that's it. Wishing you all the best. Continue with what you're doing. Always seek information. Always seek, new opportunities. All the best.
Thank you, Dr. Alya.
Thanks.
Enjoy your night.
All right. Bye.